Hi, everyone. My name is Jamie Gomes. The title of my presentation is Health Information Technology Impact on Medication Safety. First off, here is just a list of disclosures. The learning objectives for this presentation we do have some key abbreviations to bring to your attention that we'll use throughout the presentation. So here's a self-assessment question to think about throughout the presentation, and we'll come back to it at the end. True or false? Health information technologies aid in mitigating medication errors. However, teams are challenged by preventing unintended consequences. Health information technology clearly has a lot of benefits, including both workflow and safety benefits. We see technology as a great tool to prevent errors by improving the ability to identify errors that are occurring and then creating systems supported by other technology to reduce or eliminate those errors. Our access to information has also greatly improved, and that includes general medication information, access to patient information, and also supporting communication. And this has greatly impacted our human decision-making process. However, it's important to note that health information technology is not a panacea. Technology still requires human interaction and development of policies and procedures. Maintenance and upkeep is a huge issue, and technology has introduced new types of errors that need to be addressed. Over the course of this module, we will discuss technologies involved in each step of the medication use process. For the prescribing and verification steps, we will discuss CPOE, CDS, and access to electronic references. For preparation and dispensing, that includes workflow technologies, barcode scanning, repackagers, robots, medication tracking, and ADCs. For the administration step, there will be the electronic MAR, barcode med administration, smart pumps, and pump integration. And in our final step for monitoring, active surveillance and trigger tools will be discussed. So first, I'd like to introduce you all more to clinical decision support, which really we tend to associate with order entry and CPOE, but can be expanded to all different health information technologies. It's a very broad term describing various types of information to aid in enhancing health-related decisions and actions. It can be general knowledge or processed with patient information. Clinical decision support plays a huge role in supporting patient safety, and its main functions include alerting, reminding, critiquing, interpreting, predicting, diagnosing, assisting, and suggesting. These functions support three major elements of CDS, which is acting as a knowledge base, then combining knowledge with patient-specific information, and perhaps most importantly, providing a mechanism to communicate that knowledge with the end user. CDS has a number of important benefits, including increased quality of care and enhanced health outcomes, avoidance of errors and adverse events, improved efficiency, cost benefit, and provider and patient satisfaction. Since there is much variation between CDS tools, and they have the ability to impact a large number of people, both providers and patients, we should always keep in mind the 5 rights of CDS: the right information, the right person, the right intervention format, right channel, and right point in the workflow. 6 types of CDS are described and typically refer to the EHR or CPOE, but can certainly be extrapolated to other technologies. So documentation forms or templates. These limit both errors of commission and omission. They allow us to capture structured data, and these forms ensure data are gathered in a manner that allows them to be used in other CDS systems. Another type is relevant data presentation to allow the decision maker to efficiently consider all pertinent data. We have order creation, facilitators that are organized around specific diagnoses, procedures, or clinical scenarios. protocol support for often disease or specific treatment, and it helps providers manage conditions over time. Reference information sources that are most oftenly electronic and can link to general or context-specific information. And then finally, alerts and reminders to present information to providers in real time to prevent a negative action, augment a decision, or update the patient status. Just like other processes in the hospital that may be non-technology based, oversight is necessary for clinical decision support. We talk about the main functions of CDS government and content management to provide oversight of these functions. Governance is the process by which an institution decides on what content will be implemented and how this will occur, while content management refers to the organizational structures and clinical information systems used to view, manage, and update clinical content on an ongoing basis. The domains of governance include the CDS staff, who's the hospital personnel who are devoted to managing the CDS system, committees, groups of clinicians, administrators, and informaticists who are responsible for the CDS maintenance. The governance process, which is the mechanism by which CDS content is acquired, either purchased from a vendor or built internally. The customization, so that the practices can tailor CDS content. Clinical information system usage requirements, so whether or not clinicians are required or encouraged to use the CDS system. And then monitoring and feedback, so looking at the hospital's process of reviewing and evaluating the effectiveness of these systems, and then obtaining input from system end users. Both for governance and content management, CDS requires input and oversight from a broad representation of hospital personnel, including pharmacy representation. Pharmacists can play a key role in CDS governance and management because medications are a core component of treatment across the healthcare system. For medication-related CDS measures, pharmacists can provide guidance on severity and evidence thresholds, which are very important to minimize alert fatigue, and can identify important metrics and measures for monitoring, as well as provide feedback and ideas that may greatly enhance CDS features. Governance when developing and implementing CDS can be as important as the quality of the decision support itself. So in this chart here, I have what would typically fall under governance and content management examples. So governance would be prioritization. A high-level group can prioritize new and ongoing work. Consideration of impact on other systems, so having that broad oversight. The development of tools to monitor CDS inventory, so tracking what the changes are, when updates are due, and who's responsible. Assessment of the impact of changes, so what's the impact on providers, and development of channels for feedback and tools for ongoing monitoring. Content management includes taking a closer look at the knowledge management lifecycle to determine clinical need for creation, maintenance, retirement, and replacement of clinical decision support. Can develop tools to facilitate management of the information, measure the acceptance rates or effectiveness of alerts or other types of CDS, and implement end user feedback tools. So getting that information from the people who are actually responding to the CDS. Now, these types of management may go through clinical committees like P&T committees, or they might go through new committee structures specific to IS, or you may appoint a single person to review or approve the content. And different types of CDS may have different management structures. So I talked a bit about the knowledge management lifecycle in terms of content management. So here's the flow of what the knowledge management lifecycle is. You have the clinical need, then identifying and understanding current knowledge, assessment of EHR functionality, identifying implementation of CDS intervention, assessment of the impact and feedback of the intervention, and then maintenance and periodic review. It reminds me a lot of the formulary management system. So a lot of routine medication-related content management can be handled through your formulary management system if your system allows it. It's the approach we take at CHOP. So for changes that would greatly impact or change the provider ordering process or nursing medication administration or documentation process, we would take those through those normal governance processes for those groups. So why is oversight so important? As I mentioned earlier in the presentation, technology has introduced new types of errors. The term electronic iatrogenesis, or e-iatrogenesis, is now being documented as the unintended consequences through the use of computerized prescriber order entry and other health information technology. And some of these consequences are listed on the slide, such as more clicks or new workflows, taking extra time to enter orders, system demands, need for continuous equipment upgrades and system dependence, communication decisions, so whether an electronic communication is okay or whether a phone call is needed or whether face-to-face discussion is needed, as well as new types of errors like entering orders on the wrong patient. I've included a quote here from the Joint Commission Sentinel Event Alert, issue 42, which I think strongly describes the risk of technology in the human interface. It reads, "The overall safety and effectiveness of technology in healthcare ultimately depend on its human users, ideally working in close concert with properly designed and installed electronic systems. Any form of technology may adversely affect the quality and safety of care if it is designed or implemented improperly or is misinterpreted. Not only must the technology or device be designed to be safe, it must also operate safely within a safe workflow process." Really talks to how health information technology is there to support the medication use process, not to completely replace any types of errors. To better characterize potential problems with health information technology, more specifically use of a computer, the human interface, there's the McGraby classification. This classification was based on 117 problems identified from an Australian reporting system. McGraby and colleagues found that the principal source of IT-related problems is split between machine-related and human-machine interaction. The nature of the errors they found were related to data entry, data retrieval, transfer of data between systems, as well as contributing factors like multitasking or not enough training, and then general technical factors, which range from failure of one computer to software issues. This is a nice visualization of the McGraby classification. It can be used to evaluate performance in regards to technology on a broad level, but also used to evaluate specific cases. These classifications are also something to keep in mind when developing and testing technology. The line down the middle delineates human-computer errors and machine errors. Contributing factors are always human interface related, while data transfer and general technical issues are always machine related. Input and output errors fall under machine or human interface issues, depending on the context. There's a lot of literature available regarding errors related to the use of technology, but specifically referred to CPOE and the EHR. The Pennsylvania Patient Safety Authority worked to identify the scope and extent of EHR risks by reviewing events in the Pennsylvania Patient Safety Reporting System and continued to add to the classification. The events were classified by error type, like a medication error or a complication of procedure, treatment, or test, and then by the McGraby classification. 4 new classifications were determined to add to the McGraby classification. These new categories included unit errors in wrong data entry, so pounds versus kilos or weight-based dosing versus non-weight-based dosing, data entered into the wrong field, like putting a stop date in a free text field instead of providing a limit of doses, days, or stop time, misreading or misinterpreting displayed information, and default values in system configurations. The Pennsylvania Patient Safety Authority published another paper in 2017 looking at health information technology related errors. 889 errors were reported, and the most common technology was CPOE. And the three most common events were dose omission, wrong dose overdosage, and extra dose. However, there's a lot of challenges to assessing these errors, and this boils down to it's unique to how the systems were being used, or the systems were not used as intended or didn't work as expected, and also technologies do not communicate seamlessly to each other. Human interface plays a huge role in many of these errors and also creates challenges to mitigating these events. I'd also like to touch briefly on IT education. Education related to IT has shown to be very important to incorporate into professional degree programs, postgrad education, and job training. The Accreditation Council of Pharmacy Education incorporated health informatics into their 2016 accreditation standards for the Doctor of Pharmacy degree. They included health informatics, professional communication, so exploring technology-based communication tools, and then also prescription processing technology. Pharmacy residencies may also include informatics experience based on the resident's goals. I typically like to do at least a 2-week experience, although a 4-week experience is ideal. And some residents I've had have chosen to do even follow-up experiences if interested in a specific technology area. Since informatics tends to be flexible, I've also provided longitudinal experiences. I also like to do training more with my staff too, to incorporate it into the day-to-day learning. On-the-job training can vary in length of the baseline training. It's important for the staff to always have a venue to escalate technology questions. It can either be a point person or an owner of that piece of technology or their direct supervisor. Staff huddles help to get feedback in real time and provide brief education, while larger topics can be brought to larger staff meetings, and policies and procedures should be created for standardization. In addition, continuing education should be included for technology implementation upgrades. It's the role of the project team to determine and plan what this education will look like. And there's a lot of different options, whether it's general electronic communication, face-to-face and Q&A sessions, electronic education, hands-on education, as well as adding dedicated support for a time. So back to the self-assessment question from the beginning of the presentation. True or false? Health information technologies aid in mitigating medication errors. However, teams are challenged by preventing unintended consequences. And the answer is true. So remember, we discussed the term iatrogenesis, which is unintended consequences through the use of CPOE and other health information technology. Also recall the quote from the Joint Commission. Any form of technology may adversely affect the quality and safety of care if it is designed or implemented improperly or is misinterpreted. So in conclusion, health information technology is available for each step of the medication use process. However, these technologies are not a panacea and can only assist healthcare providers in the decision-making process. CDS has multiple functions to guide decision-making, but must be maintained through governance and ongoing content management. New types of errors have stemmed from use of health information technology. Human interface plays a key role in many of these errors and also creates challenges to mitigating these events. Informatics education is imperative to enhance appropriate use of health information technology across the medication use process. So with that, I'd like to thank you for your time and participation.